So it's my pleasure today to be the guest host for a conversation about vaccines. And I'm the moderator, I'm chair of the Department of Neurosurgery, but our expert is Dr. Brooks Jackson. He is the Vice President of Medical Affairs at the University of Iowa, also the Dean of the Carver College of Medicine, and he is responsible for oversight of the University of Iowa Hospitals and Clinics, which is one of the largest university-owned hospitals in the United States. He is an expert in public health research related to viral infections. So I think it's the reason we set this up is that as department chairs, Dr. Jackson has periodically briefed us on progress with the COVID pandemic and the vaccines. And many of us thought it would be interesting for our Iowa friends and alumni to hear directly from an expert like Dr. Jackson. So Dr. Jackson, thanks for doing this. And can you tell us a little bit about your background, where you grew up, where you received your training, and how it is that your career path resulted in you being with us at Iowa?
Okay, well, thank you, Matt, and welcome everyone. Yeah, I grew up in Cincinnati, Ohio. I'm a Midwesterner. I was actually a history major in college, so not a science background, although I did take science courses. And I actually went to business school at the Tuck School at Dartmouth and received my MBA and went into the private sector. But as one of those jobs, I was I was a hospital administrator, a lab manager for pathology at the Mary Hitchcock Hospital at Dartmouth. And really found it to be an extremely interesting field. Applied to medical school at Dartmouth, went there, and did my residency then in pathology at the University of Minnesota, which was really probably the top program at the time, and loved transfusion medicine. And I did my residency, a fellowship there, and really got interested in transfusion transmitted viruses because in the early 80s, of course, HIV was a huge problem for blood transfusion recipients, with some 30,000 transfusion recipients becoming infected with HIV in the country. And so it was a great opportunity, very interesting, and of course, a major problem as it turns out. And so that really started my interest in viruses. And, over my career, have really spent most of it in researching in the areas of prevention and treatment of HIV and some other viruses as well along the way with that. And ultimately, did a lot of work overseas in Uganda and China, as well as in the United States. I probably spent much of my career at Johns Hopkins and was the chair of pathology there for 13 years or so. And during that time, I conducted research in this area. One of the great things about transfusion medicine, it's the one area of pathology where we see patients, and I still see patients, have throughout my career and still do at the University of Iowa. And that allowed me to also become more involved in conducting clinical trials, both for drug treatments as well as vaccines, including HIV vaccines as well. So it's been an extremely interesting area. There's a new pathogen discovered every 8 months in the world, and coronavirus is just one more. And of course, this is a little more problematic and dangerous than many others. But it clearly is of great interest to me. I find it extremely interesting, but at the same time, worrisome, because obviously it is taking a real toll on our patient populations around the world, including in Iowa. So in terms of my experience in administration with my business background, research, and as chair of pathology for a long time at Hopkins, Being a dean was probably a good background for that in VPMA. Pathology is a fairly large department with lots of administrative responsibilities with oversight of really a large number of people. So it really did provide good experience and background for that. So at University of Iowa, which is a fully integrated health system with the College of Medicine, this was extremely appealing to me, and I've loved it since I've been here 3 years now. So,
Dr. Jackson, can you tell us a little bit more about your experience in Africa? I mean, it sounds like an extraordinarily challenging environment to set up a major research program like you did. So tell us about that.
Yeah, so, in the 80s, obviously, HIV became a huge problem, and Uganda was probably at the epicenter back in the 80s in Africa. And I was very fortunate to have as a mentor a dean, actually, Fred Robbins, who was also a Nobel laureate for his discovery work in polio. And he had conducted actually a number of polio vaccine trials in Uganda back in the 50s and had a lot of contacts there. And after Idi Amin, Milton Obote, in 1986, after that, Fred was able to get some NIH funding to set up some epidemiologic studies, and he needed somebody that had laboratory expertise. And I had set up a number of assays for HIV, and so went with him there to set that up. And, I became very involved in the types of studies done there, and became involved here in the United States with the AIDS Clinical Trials Group, both for adults as well as maternal infant drug treatment and prevention studies, which we carried over to Uganda over that literally 30 years. I've been involved with research there, as well as in China. So that's where we did some of our vaccine trials as well in Uganda in particular. So,
Dr. Jackson, what is it that, you're going to go into this in some detail, the University of Iowa played a particularly important role in the testing and planning of research related to the current COVID vaccines. Can you tell us about what role you and your colleagues like Dean Winokur and others played in what is, for most of us in the United States, the most pressing and disruptive public health challenge we've ever seen in our lifetimes?
Well, we are fortunate to have some really great faculty in the area of diagnostics, as well as the ability to be able to test, hundreds of people a day. Brad Ford in pathology in particular, in microbiology, quickly set up PCR assays for the detection of coronavirus here with incredibly good turnaround time, 6 to 8 hours, even today, where people sometimes are waiting days for this. And at the same time, faculty like Katie and Boric and Doug Van Dale with our influenza-like illness clinic are able to literally test, well over sometimes 1,500 people a day through our drive-through clinics here on campus, as well as out at Holiday Road, Old Cap. So, we have been extremely responsive to the need for testing, as that is clearly something that is extremely important to be able to get people into treatment, as well as to make sure people self-isolate if they are infected so it doesn't spread. And we have done an incredible job here. As I said, it's a fully integrated health system with really great faculty in terms of infectious disease as well, especially with regard to testing. Not to mention the vaccine areas as well, which we can talk more about.
So Pfizer seems to be slightly ahead of the other manufacturers of these vaccines. How is it that Pfizer teamed up with the University of Iowa, and the University of Iowa ended up being one of the leading centers for their trial?
Yeah, so Pfizer, of course, is one of the largest pharmaceutical companies in the world. And they did this in conjunction with a company in Germany, BioNTech, that really developed this really brand new, utilizing this new technology of messenger RNA for this vaccine. And for us, I think we were a very attractive site for Pfizer, because faculty like Pat Winokur, who's our executive dean and also an infectious disease expert, has been our head of the NIH-funded vaccine evaluation unit here at Iowa for a number of years. So we have a great infrastructure and track record for conducting vaccine trials here. So I think that is one of the reasons we were selected for their phase 3 trial here. And, credit to Pat and her team, we were able to enroll extremely quickly into the Pfizer trial. They are ahead, I think, partly because they were able to get 120 sites set up very, very quickly. They are leading by just probably a few weeks ahead of a couple of the other companies. But they were able to enroll very quickly, and it's because of sites like ours that they were able to do that had the experience. So we're very excited about it. Many of our healthcare workers, including myself, enrolled in the trial. I enrolled the very first days of the trial. So we're very pleased that we were able to contribute to this effort.
Dr. Jackson, the rollout of this COVID vaccine has been front and center in the news. It's been tied into the political landscape. But even those sort of macro issues aside, it seems as though this viral vaccine development project is fundamentally different than previous ones. And can you tell us about the unique design of these vaccines, and how is it that this has made it possible to progress so quickly?
Yeah, so this vaccine uses a different technology than has been used before. Typically, vaccines in the past, some have been live attenuated vaccines, some have been inactivated dead virus. Some have been subunit proteins used with an adjuvant. Some have put into a different viral vector, such as adenovirus, which are all still being used in some of these vaccines for COVID coming up. But this one used messenger RNA, in which, with a nanolipid particle, enveloping this messenger RNA, which encodes for, in this case, the spike protein of the coronavirus, which is the most immunogenic antigen of the virus, is able to, through an injection, enter cells and uses the cell machinery to produce the spike protein, which it doesn't integrate into the host DNA, but produces the protein that is, as well as part of the cell membrane, so that in two ways. One, the spike protein is presented to our immune system and will make antibody to it. At the same time, it's presented to T cells on the cell surface, so that you get a cell killing by the T cell. So it will eliminate this messenger RNA, but only after it has produced a fair amount of spike protein and we get a good immune response. And we're seeing literally, 94, 95% efficacy with this technology, which typically we do not get that high. I mean, measles vaccine we have, but hepatitis B vaccine, we don't typically get that high. Certainly flu vaccine, we don't get that high, which is often maybe 50% efficacy. So this is really very promising and very likely to be extremely effective. And the trials so far using this technology have been 94, 95% efficacious.
So biomedical research of this level of sophistication, where they're defining what this spike protein is, and then coming up with some way to cause your own machinery to attack the spike protein, it's a global enterprise. The developed countries all have very sophisticated molecular biology researchers. What was the sequence from the time that the infection, the pandemic started in China? How did they figure out what that spike protein was?
So, the Chinese, obviously in Wuhan province, the first report came out, I think, the second week of January, and the genetic sequence was the second or third week of January. And within 66 days, literally, they were able to develop the vaccine for this, which is really incredible. I've been in HIV a long time. HIV was discovered back in 1983. Here we are 37 years later, and we don't have an effective vaccine for HIV, partly because HIV just mutates so quickly. And one of the advantages against coronavirus is that it doesn't mutate very much. So it stays relatively conserved. So the antibody to the spike protein should remain effective against it for some time. I do think the antibody levels will decrease over time, but so far they seem to hold up pretty well, at least for a few months. And I suspect it'll be longer than that as well.
So one of there are several issues related to how it's going to impact public health. Its efficacy of these vaccines is extraordinarily high, but for that to have an impact on public health, people have to be vaccinated. So there are practical issues with this vaccine. They're a little different than other vaccines. And because it's such a huge pandemic now, you have hundreds of millions of people who should get the vaccine. You're going to start with a limited supply. What is the game plan for rolling this out, so to speak?
Well, so with this vaccine in particular, which Pfizer has submitted on Friday, the emergency use authorization to the FDA, it's expected that the Vaccine Advisory Committee at the FDA will review this December 10th, and then the CDC within 1 to 2 days after that, and assuming the safety profile looks good and verify the efficacy data that's been reported, which we fully expect, we do think that vaccine will be available, around December 15th. Now, the government has contracted with not just Pfizer, but other companies to provide hundreds of millions of doses, and for free for people. We expect to get vaccines, some allotment. Apparently it's being distributed according to population. We're about Iowa's 1% of the overall U.S. population. I've heard Pfizer may have 40 million doses by the end of December available, which would mean 400,000 doses for Iowa. It wouldn't come on the first day. We have storage ability for 60,000 doses at one time for Pfizer, and the other company, Moderna, which also uses similar technology, which is close behind, 90,000 doses. It's a 2-dose regimen. So 3 weeks apart for the Pfizer, 4 weeks apart for the Moderna. So we hope to be able to have more than one vaccine available, and healthcare workers will be prioritized apparently, as well as first responders and residents of long-term care facilities, older people. But we plan to have vaccine available in probably less than 3 weeks that we can start vaccinating. We don't know how many doses we're going to get at this point. As I said, I don't think we'll get the full 60,000 on December 15th, but if we were to get 10,000 or so, we could vaccinate 5,000 people because it's 2 doses. Remember, we have approximately 18,000 different people at UIHC here, so that's a large number of people. Not everybody has frontline patient exposure, but a lot of people do, from dietitians to custodial staff to doctors, nurses, pharmacists. So it's a lot of people that we need to vaccinate. And, you know, there's always the worry about, will people take the vaccine? The safety data look very good with this vaccine. The phase 1/2 data look very good. I mean, I reviewed it. I signed up based on 24 people taking this vaccine back in July. The data here looks very good. There are reactions, feel crummy for a day or so, but it's acceptable. We have our flu vaccine, typically 92, 93% of our healthcare workers get the flu vaccine. It's voluntary, and we get that high a level of participation. And I think we're going to get a high level of participation with this virus, with this vaccine, just because the risk-benefit ratio is so good, the benefit compared to the risk. This can be a nasty, bad virus that obviously has killed already 260,000 people in the United States.
So Dr. Jackson, you touched on a critically important issue, which is the notion of safety. What people, when they're making this decision, they're likely believe this is highly effective, but you hear so much about issues, safety issues related to vaccines. And in our discussions before, I was very impressed by even doctors, when we're trying to make a decision about a medical intervention that involves safety, we go to another doctor who really has the experience that we need to know, well, what would you do? So you signed up for this vaccine when there was safety data on 24 patients, if I heard you right.
With this dose, yeah.
With this dose, there were 24 patients, but you've grown up in the culture of vaccine development, so you totally understand these issues. When the public has this opportunity to get the vaccine, how many people, there will be safety data on how many people?
So in this particular Pfizer trial, 44,000 people were enrolled into this trial. And as I understand it, they have the safety data on about 42,000 of those patients. Moderna, which also same technology, about 30,000 patients. So we have a total of almost 75,000 patients that have gotten these vaccines. And normally in vaccine trials, we're looking at 2,000 or 3,000. So this is like 20 times that number, which gives us much more confidence and assurance about the safety. Now, it's not as long as we typically follow people, but that's a lot of people. You know, I've been vaccinated well over 70 times with probably at least 20 different vaccines. You know, there are some reactions with some. You know, your arm is sore for a day or two. You may feel some fatigue or get a headache. And it's true with this vaccine as well. You know, I would say of the older people in the data that's been presented, the majority of older people that got this particular vaccine did not have reactions. It seemed to be more common in younger people, but 24 hours or so, felt crummy. I mean, but given the potential benefit, you know, everybody has a different risk tolerance. There's no question about it. But I think in this particular case, you know, the benefit far outweighs the risk at this point. So
it's going to take a little while to get, even though in some ways it's right around the corner. We're talking a few weeks where the vaccine will start to be administered. We're in the midst of a surge. I mean, we really have a big problem in Iowa and across the nation. As we're navigating this pandemic as caregivers, of course, we're monitoring things day by day in our hospital because we don't want to reach a point where we're overwhelmed and we just can't take care of anybody. What about the basic blocking and tackling of mask wearing, social distancing, and what have you seen? You've followed these statistics very carefully through the whole pandemic. What is your take on that? And what's the word right now? What do you see right now?
So, yeah, obviously we had a surge back in March and April. And then again, clearly here when the students came back, several thousand students became infected. Fortunately, none of them had to be hospitalized and it did not spread into the community. But we're seeing a huge surge again that is really community spread right now. And, you know, there's probably some seasonality to this virus, like most respiratory viruses, which I think is contributing to the surge we're seeing. It's not just Iowa, we're seeing it across the upper Midwest, Northern Europe, where we're seeing very, very large numbers. And we certainly have seen it here as well, especially starting about 2 or 3 weeks ago, where, you know, back in June, we were running some days where there were no patients that were testing positive. And then we spiked on like November 5th at about 222 positives. And we'd had only about, you know, 10 to 15 inpatients with COVID a month or so ago. And we peaked several days ago at 99 patients. But fortunately, in the last week, we have seen a dramatic decrease in the number of positives. Like we had 68 positives yesterday compared to 222 2 weeks ago, and we're, you know, slightly down from 99 inpatients to 87 inpatients today, which is a good sign. And I think part of this is clearly, you know, the people are being more careful, wearing their masks, social distancing, hand sanitizing. And I think it's extremely effective. You know, I have been here, you know, literally every day when I am here on campus 7 days a week, 60 hours a week in this hospital, and see patients, work with COVID research in the lab. And you know, I think if you follow what we have been recommending, you can really be safe. Now, unfortunately, we've had up to almost 500 healthcare workers at one time either be infected or exposed, which has limited our ability to take care of patients. Now, that too has come down, and we're at about probably 250, 220 right now. So that is an issue. And it's not so much they're getting infected at work, but it's really hard to keep your guard up 100% of the time, especially around family. And that's where we're seeing where, you know, a lot of our workers and other people are getting infected. And so really trying to minimize that interaction. And we're going to have to do that over the next several months for sure. But hopefully vaccines will be, like I said, will really be rolling out. It will take till April or May till we can get the general population vaccinated. But I think this is really great news. I mean, it's really good reason to be optimistic at this point. And we have new therapies. Today we enrolled or had our first FDA authorized the use of bamlanivimab, which is a monoclonal antibody for patients, outpatients with mild or moderate symptoms, which we're offering at IRL today. And it, you know, preliminary studies are showing a, you know, 70% reduction in hospitalizations with this monoclonal antibody. People probably saw Regeneron was also authorized use Saturday by the FDA. So we are making real progress, not only in vaccines, but also treatments. So, you know, this is incredible considering it has, you know, it's been less than a year that we have made such progress.
So to clarify, the antibody treatment that the president received, that's now available here at the university?
Well, the Regeneron—
Or a variant of that strategy?
Well, the bamlanivimab is very similar to the Regeneron. That is available today. The Regeneron is authorized. We still don't have it. We have it in a clinical trial. We do have it for inpatient clinical trials as well as outpatient for a clinical trial, but it's a randomized trial with placebo. Whereas the Regeneron that was just authorized, anybody can get it that meets the criteria as an outpatient, mild, moderate symptoms, but we don't have it yet. We hope to have it in the next week or so. So that's also good news.
So at this point, what we'd like to do is open up the chat to questions. And I might look to Tony for some technical assistance if I can't, if Dr. Jackson and I can't see these questions, but please go ahead, and those who are on the call, send some questions.
So Dr. Howard, if you click on the Q&A button on the bottom of your screen.
Okay.
And open that, you should see some questions in there.
Okay. These are good questions. All right, so here's one, Dr. Jackson. I've heard people with autoimmune diseases are very worried about taking the vaccine. Is there any reason they should, the patients with autoimmune disorders, be dissuaded from taking the vaccine?
Well, I think we have to see the data on that, and we have not seen that. So, I think it's premature to say whether it's safe or not for patients with autoimmune disease. And there are a lot of patients with autoimmune disease, so we don't know about that. I think it's the same. We don't have data on transplant recipients either. So there are, or in pregnant women. So there are some groups we don't have enough data at this point.
Have patients with those disorders been enrolled in the trial, and it's just going to take some time to figure it out?
I do not believe the transplant recipients, I do not believe have been enrolled. We should ask actually Pat Whitaker. And I don't believe if they had autoimmune disease they were, but I may be wrong on that. So
I see. They may have been excluded from
the trial. They may have been. There were some people who were excluded.
So here's a good question, and it has to do with COVID testing. Essentially, the question boils down to this: what are the different kinds of tests, and how sensitive and how specific are those different tests?
So the PCR test, which detects the actual RNA of the virus through the nasal swabs or oropharynx, are very sensitive and specific. They're quite good, 99% plus. They are, because there are literally hundreds of millions of copies typically of the virus, especially early in the infection. Obviously, later in the infection, where you develop antibody, you may become negative with this test, or if it's too early from the time of exposure, it may be negative. But typically, when symptoms are starting, it's very predictive, sensitive, and specific. Now, there are other tests, such as saliva, that has been used, and it too, some show that it's pretty sensitive and specific as well. Obviously, predictive value of a test depends on prevalence in the population. And so, if you have a very low prevalence, even if you have 99% specificity, you're going to get some false positives when you have extremely low prevalence. So you always have to keep that in mind.
When a person is either infected and recovers from the COVID infection, or receives the vaccine, which we now know is 95% effective in preventing infection, how long is the duration of protection? In other words, when do you have to worry about being reinfected?
Yeah, so there have been some case reports of people who have had COVID who have recovered and then seem to have relapsed with COVID. they're very few, out of, whatever, some 50 million people, maybe a dozen have been reported. So it's potentially possible, but it seems to be extremely low. Data recently published from Iceland showed antibody levels staying very high for at least 4 months after COVID infection. And interestingly, the Pfizer vaccine and Moderna vaccine shows antibody levels that are neutralizing antibody levels higher than actual natural infection. I suspect, like with most diseases that one develops antibody to, antibody titers tend to go down over time, but that doesn't mean that you won't be protected. And so that we don't know, but I suspect as long as you have detectable antibody, and even if you don't have, you become undetectable. In many of these other infections, we still see protection from disease. We see that with hepatitis B, for example, with very low levels of antibody, or even losing antibody, we can still see protection. So the bottom line is we don't know how long it's going to last. We really don't, but so far it looks pretty good at keeping these antibody levels up. And of course, there's cellular immunity too. So it's not just humoral or antibody levels that matter. So we'll just have to keep following up and see, because we only have a couple months of data with well, probably a little more than that, probably 3 months now with the Pfizer vaccine. So
as a non-expert, I think about broad categories of vaccines insofar as their duration of effectiveness. For example, a measles shot and the polio vaccine, it seems like we only get that maybe once. Whereas the flu vaccine, every year we line up for that flu vaccine. So what's the difference between those two?
Well, I think part of it is just, how quickly the virus changes. And with flu, it can change year to year. It does change year to year. So we're always redesigning the vaccine to take into account the new strain of virus. Others, like measles, seems to give you lifelong protection against measles. And of course, some vaccines are better at generating long-lasting immunity. I mean, I got the hepatitis B vaccine back in 1983, and I still have good antibody to hepatitis B with just that one type of vaccine. So they do vary quite a bit. So we'll just have to see how long this one lasts.
We'd asked about discussed a little bit about testing whether you're infected or not. What about the test for antibodies? We can draw blood and see whether we have antibodies and what the levels are. What role do you see for that kind of test?
Yeah, so the antibody test, which we set up at UIHC back in April, and is available to anybody who wants a COVID antibody test, which gives you some idea whether you've been infected or not in the past. And remember, the CDC is estimating, a potentially as many as 40–50% of people that are infected with COVID are asymptomatic, never develop symptoms, but you will develop antibody typically. And so this is a good way for surveillance testing to actually see what percent of the population has either had symptomatic COVID infection or asymptomatic COVID infection, and gives you some idea what percent of the population is presumably protected and what percent is at risk and susceptible, which is very important to know, what the prevalence is of protection in the community. And it varies. There have been studies of this in around the world, as well as in the United States, and states like New York have especially New York City, where they had such a huge surge of cases back in April. I was reading have as much as 27% of the population may have antibody, whereas in California, at least couple months ago, it was maybe only 6% or so. So it really does seem to vary, but gives you some idea whether you've actually been infected already or not. We could use that to see potentially if you have limited vaccine, you could potentially test people to see whether they have antibody or not first before you give the vaccine.
And as I recall, you and your colleagues, or maybe another group at the university, is studying pregnant patients.
Yeah. So, yeah.
So what's that study about?
Well, there are, pregnant women are tested for virus when they deliver it at the hospital, and tested for antibody as well. And, in the first, since May 1st, about 1,000 have been tested, and it was about a 6% prevalence for antibody, but it has since gone up fairly significantly to 13 to 20% more recently. So, clearly community spread is out there. Now, the majority of these women, they're young, obviously, are asymptomatic. So far, it does not seem to be put them or their infants at risk at this point with our preliminary data. But, we need more data to keep following up and see. But this is reassuring to at this point. But it also gives you some idea about the general population, because pregnant women really cut across all socioeconomic classes and geographic, certainly in southeastern Iowa. So you get a good idea what the prevalence might be, at least in this younger population. I suspect it's much higher in the younger population than in the very old population, who have been much more careful about protection. Although our long-term care facilities, as we know, this has been a problem with infection in these nursing homes and long-term care.
So I have one final question, and then I think we're going to have to wrap it up. And that is, will there be a recommendation for children to be vaccinated?
I think there will be, but the Pfizer vaccine did expand the number enrolled. Originally, it was 30,000, then up to 44,000. And they did get permission to enroll children over 12 years of age. So 12 to 18, this is a new group. So we're getting data on them. I don't think we've seen the data on that group at this point. But, typically with drug trials or vaccine trials, we do adults first before we go to children. And so they're going to be behind. This is very typical. And so I think we will keep going down in terms of age as we get more safety data in the adults and the teenagers, and ultimately the younger children as well. Fortunately, the teenagers and children, their risk of serious disease is really quite low. It's not to say it's zero. It's not zero, but it is much lower. But so I think we want to protect them ultimately as well. So,
Dr. Jackson, thank you so much for spending this time with us and sharing your expertise in the field, and also telling us what's going on at the University of Iowa as it relates to the COVID pandemic and the vaccine. And thanks to everybody, all our Iowa friends and alumni, for participating in this Capitol Chat. Tony.